I often start this talk about viruses, and this is an image of my youngest daughter. And this is when she was at preschool and she was dressed up like a doctor. And the reason that she's usually there is to illustrate the point that children are usually the biggest source of virus transmission. But in COVID-19, that's probably not the case. But I like the picture, so it's there anyway. Oops. So in order to be able to tell you about face masks and their utility, I do need to explain a little bit of airway physiology. So simplistically speaking, we have our trachea, which is our windpipe. So this is quite a big tube. And then these tubes get progressively smaller, and we're not very inventive in respiratory, so we call the big ones the large airways. And then as they get smaller, we call the small ones the small airways. And the small airways become so small that we can only visualize them using a microscope. And the small airways are the site of all the action in respiratory. So what we have here is an alveolus. So this is where gas exchange occurs, and we've got these small airways. And when we breathe out, especially when we breathe out forcefully, our lungs collapse. So imagine a sponge that you're wringing out, and these small airways come together. And as we take a deep breath in, this image, which is actually from a publication, is wrong. What happens is that as the small airways come apart, we get this rupture bubble, but it's actually going in the opposite direction. I suppose it doesn't really matter, but in the case of being correct, it's wrong. Now, what that does is then creates droplets of airway surface fluid. And if the person has an infection, there's a potential that these droplets could contain the pathogen. The other thing that also happens is that in the alveolar space, there's evaporation of a range of things, including water vapor. And I'm sure that on a cold day, we've all breathed out, or we've all seen water vapor in front of us. And for the most part, we ignore it. We don't really think about what's contained in that water vapor or what it could be doing to us. Now, much like Tamsin, I've been interested in what this means and what it doesn't mean. And I'll go on to the history of this in just a moment. But just to summarize, what can happen is that during breathing, these droplets are released into the air. The droplets can either fall rapidly or they can partially evaporate to form what's called droplet nuclei. And the reason that these two things are important is these give rise to two concepts. So the idea that they fall rapidly gives rise to the notion of how far away from people you need to be. So some research that was done a long, long time ago indicated that when people are exhaling particles, those particles would drop within 2 meters. So that's why we have this 2 meter distance. But in fact, this evaporation and droplet nuclei is actually more of a worry, because when we breathe out, these particles evaporate and they can remain airborne for hours. And it's been shown with COVID-19 that there's actually airborne COVID-19 for up to 3 hours after an aerosolization event. And a lot of interest in this area is really sparked up again due to the increased transmission of COVID-19. So I started all this research about the time of bird flu, and then swine flu came along. So with each successive epidemic and pandemic, my research gains more momentum and more focus in this area. So this is the slide I actually thought was coming next, and this will be of interest to Tamsin. And this is our understanding of aerosolization of respiratory viruses. So this is relating to influenza, and this document's over 100 years ago. And if Zoom lets me move this little thing, which it does, good. So what I'd like to point out here is that 100 years ago, they said the disease is spread by the moist secretions from the noses and throats of infected persons. Avoid being sprayed by the nose and throat secretions of others, and beware of those that are coughing and sneezing. And really, for 100 years, we haven't progressed much. This is still the sort of rhetoric that comes up. And at the start of COVID, this is exactly what happened. We thought that this is the only way that the disease could be transmitted. And you probably all remember that the public health advice at the beginning was not to wear masks, because they were thought not to be an airborne transmission, they were thought not to be useful. And look, sometimes we learn from history, but sometimes we repeat the same mistakes. Now, if you're wondering whether or not aerosol spread of COVID-19 is real, this is probably the most striking example that I can think of. There was a choir practice in America, And from that choir practice, there was one index case of one person that was positive with COVID-19. The choir practice took place, it lasted a couple of hours. From that, 32 other people became infected. And it's important to note that these people were actually physically distanced from each other. So they weren't touching each other, they were washing their hands. And of those 32 people that were infected, unfortunately, 2 of them passed away. So this is actually not a good news story at all. But it does illustrate that aerosolization and spread of COVID-19 is possible. So, and this was really one of the typical, archetypical aerosolization studies on COVID, which led people to start reevaluating whether masks would be useful or not. What we've done in terms of masks is we've used the material that's inside them, which is called Electret. And simplistically, this is just a nylon fiber that's permanently electrostatically charged. And Electret's used in all sorts of things. So it's used in dusters at home, it's used in face masks, it's used in air conditioning filters. So as a material, it's special because of its electrostatic charge, but other than that, it's not too special. And what happens in the case of a face mask is that the material is loosely wound together. So it forms both a physical barrier because there's holes in it, but in fact, the electrostatic charge is what's important. So if you were to breathe through this and there was a virus in there, the virus would stick to the Electret. And just to illustrate that, this is an electron micrograph, and this is actually dust particles. And you can see in the image on the left, which is an electric fiber, there's many more dust particles stuck to it than the regular fiber on the right. So we took the Electret material, and you can see at the end here, it's the white, almost cotton wool-like material here and here. And we were doing a study in children, and we wanted to know if we could use Electret as a sampling medium. So we created 3 different types of face masks. This one is, it's actually just a coffee cup, but it was made to look like a mouse, and we thought that that might be appealing to kids. This is a more medical mask, and this is something that we came up with. This is a PVC face mask with the Electret filter. Turns out children really preferred wearing this type of mask, so that's what we used. And using that type of mask, we then asked student volunteers, and these are people around age 20, to either talk, breathe, or do have 20 simulated coughs, so just go that type of thing. We also used the same masks and put them on children out at the Children's Hospital of Westmead, and they could do anything for 20 minutes. And from that, this is what we found. So if we looked in nasal mucus, and that's typically the gold standard when you're looking for respiratory virus, you can see that all these patients had virus present in their nasal mucus. This patient here only had virus present when they wore the mask when they were pretending to cough, whereas the other patients, so the 2 middle patients, have got virus present in all samples, and across here, this patient was negative in the coughing. So this was actually the first illustration that aerosolization of virus was possible just through things like talking and breathing. And this is sort of an interesting story, which I won't go into at the moment, but we did this on the smell of an oily rag, and there was a group in America that got a $5 million US grant, and we beat them to it. So it was sort of a nice win for Australia. But I'm not advocating for doing things on the smell of an oily rag either. We've progressed our technology. We've made different types of filters. We've made different types of devices. And Alicia Mitchell, who was a PhD student at UTS, she's now graduated. She actually used a commercial filter, which is called a spirometry filter, and did a very similar study. But what Alicia did was to actually test patients in hospital that had a respiratory disease, but had no signs or symptoms of respiratory virus. And quite amazingly, what she found was that in up to 80% of people, we could detect a respiratory virus in the absence of symptoms. And then this led to another new notion of asymptomatic infection. So my PhD was in respiratory virology, and when I did it, there was no such concept of asymptomatic infection. You either had the virus, you had symptoms, or you didn't. So this particular study helped to further reinforce this concept of asymptomatic infection. And in fact, in COVID-19, studies have shown that between 20 and 80% of people do have an asymptomatic infection. So if you think that screening people for temperature is going to be sufficient to protect you from COVID-19, it's not, unfortunately. Now, my talk's really about masks. And when we think about masks, there's two types. There's surgical masks, which are the ones over here, and there's N95 or P2 respirators. These actually differ in what they do. So a surgical mask is actually designed to protect the patient from what the surgeon's coughing out, and predominantly to protect the surgeon from body fluids entering their mouth, so blood splashes or other body fluids. So a surgical mask is not really designed as a filter for anything, but they do work as a filter because they contain Electret material. The N95 or the P2 masks, on the other hand, are actually the type of masks that are designed to act as a real filter. Now with N95s and P2s, these are predominantly designed to protect the wearer. So these are used in industrial applications where people work in dusty environments. They're used by healthcare workers. But these are designed to both, they act as a filter for both inhaled and exhaled air, whereas these ones predominantly work in the case of disease transmission by protecting. So if I was to wear one, you'd be protected from me. But if I wear one and you're positive and you're not wearing a mask, it doesn't actually afford any protection to me. Now with P2 and N95, there's lots of different varieties available. And the major issue with them is that if they don't provide a tight seal to your face, they're actually ineffective. And some studies that we've just completed and we're trying to publish shown that in frontline health workers in Sydney, only 50% of people pass the test, what's called a fit test. So these masks just don't actually fit 50% of people that are working on the front line. And if we put that into an Australian context, we know that 3,500 healthcare workers in Victoria have become positive with COVID-19. And of that 3,500, 2,500 of those infections definitely happened at their workplace. So these masks, even though they're brilliant, if they don't fit to your face, they're actually no use whatsoever. So for example, if you're a man and you've got a beard, they just don't provide a tight seal. If you've got an unusual shaped face, they don't provide a tight seal. And one thing that I've seen, which is really worrying, is that you see a lot of these P2 masks with what's got an exhalation valve here. So these masks are quite difficult to breathe through. And this is designed to make it easier for people that work in dusty environments to breathe, make the mask more palatable. But the difficulty here is that in the case of COVID-19, if someone's got one of these, they may as well not be wearing a mask because there's actually no protection to you from someone wearing this type of mask. So the question really is, are masks useful? And I know this is an incredibly busy slide, but this is the best evidence we have today. So each listing here is an individual study. And what this is a systematic review and meta-analysis. So they've taken the data from all these individual studies and combined it together. Now, on an individual study basis, what we can see is, say, up here. So this is the mean data, and this is the standard deviation around the mean. And if that standard deviation crosses this line where there's no effect, that study would be said to be ineffective. But by taking all this data and adding it together, what we get is an average value, which is down here. And that average value says that wearing masks reduce your risk of catching a viral infection if you're a healthcare worker by about 60 or 70%. And if you're working, if you're in a non-healthcare setting, there's still a similar protection afforded by wearing a mask. So our data actually strongly supports the wearing of masks to both prevent the transmission from the infected person and to prevent the infection of a non-infected person. I'm happy to answer more questions around this if people have it. Now, I'm sure that there's lots of clever people on the webinar today, and you probably have seen my title, which is a little bit unusual, which is Where Face Masks Are Useful for COVID-19, and it's WHERE. I saw what I'd done when I gave the title for my talk, and I thought, well, I better try and save some face. So where are face masks actually useful? I think face masks are useful in any context where there's two humans coming into contact with each other, in the case of COVID-19 being prevalent. So in other words, if you're in the park and there's no one around you and there's no one likely to be around you, wearing a face mask is not going to help. It's not going to do particularly much. But if you're on a crowded train, if you're in a public space where there's other people around, it's really important, excuse me, to wear a mask. I'd like to finish by this example of where not to wear a mask. So some of you will recognize this corridor, it's quite close to UTS. And this young chap down here is wearing a mask, but as you'll notice, it's actually protecting his chin. So an awful lot of people do wear masks, but they don't actually wear them appropriately. So if the mask isn't covering both your mouth and your nose, you may as well not bother at all.